Hello my dear curious and studious students of surgery. Myself Dr. Mahesh Chaudhary. I am warm welcoming you in my surgery lecture series. This surgery lecture series contains entire surgery with anesthesia, with radiology, with orthopedic. So stay tuned with us. Let's start our surgery lecture series. Welcome dear students in my surgery lecture number 71, that is the shock. In this lecture we will cover the types of the shock, that is the haematogenic or hypovolemic shock, traumatic shock, neurogenic shock, cardiogenic shock, septic shock, and the clinical features of the shock and its treatment of every shock individually. Now let's start with the shock. It is very difficult to define a shock in one sentence. Probably the best definition would be shock is a condition in which circulation fails to meet the nutritional needs of the cells and at the same time fails to remove the metabolic waste products. It is a peripheral circulatory failure which results from a discrepancy in the size of the vascular bed and the volume of the intravascular fluid. The low blood flow state in vital organs is the main cause of shock. Now there are various types of the shock like haematogenic or hypovolemic shock, traumatic shock, neurogenic shock, cardiogenic shock, septic shock, and miscellaneous types of the shocks. First, we start with the haematogenic or hypovolemic shock. This type of shock is due to the loss of blood, plasma or body water and electrolytes, or in one word, loss of intravascular volume. It is often caused by the hemorrhage, vomiting, diarrhea, dehydration, etc. The characteristic features are decreased filling pressure of the heart, decreased systemic arterial pressure, tachycardia, and increased vascular resistance. This is clinically manifested by low cardiac output, tachycardia, low blood pressure, and vasoconstriction revealed by cold, clammy extremities. Now, second is the traumatic shock. This type of shock is caused by the major fractures, crush injuries, burns, extensive soft tissue injury, and intra-abdominal injuries. In this type of shock, hypovolemia due to bleeding both externally and internally, that is the intraperitoneal hemorrhage, from ruptured liver or spleen, or from torn vessels of the mesentery along with toxic factors resulting from the fragments of tissue entering the bloodstream. Shock due to the burn occurs as a result of the rapid plasma loss from damaged tissues. This causes hypovolemia. This becomes worse with more than 20% of the whole body surface burns, in which there occurs generalized capillary leakage in the first day, leading to gross hypovolemia. Toxins liberation from infected burns also aggravates shock. This causes an intravascular inflammatory response with increase in vascular permeability, which requires large volume of colloidal and crystalloidal fluids for resuscitation. Now third is the neurogenic shock. This is caused by the paraplegia, quadriplegia, trauma to the spinal cord or spinal anesthesia. Such shock is primarily due to the blockage of the sympathetic nervous system, resulting in loss of the arterial or venous tone with pooling of blood in the dilated peripheral venous system. The heart does not fill normally, so that the cardiac output falls. So there is a low blood pressure with a normal cardiac output and normal pulse rate, a warm dry skin. Vasovagal or vasogenic shock is also a part of the neurogenic shock, in which there is a pooling of blood due to the dilatation of the peripheral vascular system, particularly in the limb muscles and in the splanchnic bed. This causes reduced venous return to the heart, leading to low cardiac output and bradycardia. Blood flow to the brain is reduced, causing cerebral hypoxia and unconsciousness. This condition can also be corrected by the Trendelenburg position, which increases cerebral flow and consciousness may be restored. Then psychogenic shock, which may follow sudden fright from the unexpected bad news or at the site of the horrible accident, is also included in this group. Now next is the cardiogenic shock. This type of the shock is usually caused by injury to the heart, myocardial infarction, cardiac arrhythmias, or congestive cardiac failure. In this condition, the heart fails to pump blood. The left ventricle mainly fails, so that there is a overdistension of the right ventricle, and ultimately there is increase of the back pressure in the pulmonary capillaries. In case of massive pulmonary embolism, if the embolism obstructs 50% of the pulmonary artery, it will cause acute right ventricular failure. This will severely reduce venous return to the left ventricle, and thus the cardiac output falls drastically to cause the severe cardiogenic shock or even sudden death. Cardiac compressive shock is usually caused by the pericardial tamponade, tension pneumothorax, or by the large diaphragmatic hernia. This is a type of the cardiogenic shock in which the heart is compressed from the outside, leading to the failure of the pumping mechanism through the heart itself is normal. Now next is the septic shock. Such type of shock is most often due to the gram-negative septicemia. Such type of shock may occur in the case of the severe septicemia, cholangitis, peritonitis, or meningitis. In early stages, cardiac output increases but vascular resistances decrease due to the dilatation cutaneous arteriovenous shunts. In late cases, the vascular permeability increases so that the blood volume decreases, leading to the hypovolaemia. In further advanced cases, the cardiac function is damaged due to the toxin liberated by the organism. Now the next entity of the shock is miscellaneous shocks. This includes unclassified types of the shock, that is the anaphylactic shock, insulin shock, etc. Anaphylactic shock is commonly seen after the penicillin administration or administration of the serum, dextrose, anesthetic drugs, etc. Such shock is usually caused by the bronchospasm, laryngeal edema, and respiratory distress, which totally lead to hypoxia. This is aggravated by the massive dilatation, which causes hypotension and ultimately shock. Now, in the detail, we will see first the hypovolemic shock. Such shock is usually due to the sudden loss of the blood volume or loss of the fluid from the vascular space. It is a hemorrhagic shock, which is the most common form in the group. Hemorrhage mostly occurs from the systemic venules and small veins, which usually contains about 50% of the total blood volume. Loss of blood will cause decreased filling of the right heart. This causes decrease of the filling of the pulmonary vasculature, which is turn decreases filling of the left atrium and ventricle. So, left ventricle stroke volume also decreases by the Frank-Starling mechanism. This causes a drop in arterial blood pressure. Now the compensatory mechanism which occurs from the hemorrhage includes the adrenergic discharge, hyperventilation, release of vasoactive hemorrhage, collapse, reabsorption of fluid from the interstitial tissues, resorptions of the fluid from the intracellular to the extracellular space, and renal conservation of the body water and electrolytes. Now first, the adrenergic discharge causes constriction of the venules and small veins, increase of heart rate, and also constrict the vascular sphincters in the kidney, splanchnic viscera, and in the skin. Second is the hyperventilation. This occurs in response to metabolic acidemia, which develops shortly after. And third is the release of the vasoactive hormones. Low perfusion of the kidney leads to release of a hormone known as a renin from the juxtaglomerular apparatus. Renin liberates angiotensin first from the liver, which is converted to the angiotensin second by the lungs. Angiotensin second is the potent selective vasoconstrictor. Now fourth is the collapse. Assumptions of the recumbent posture due to the collapse automatically displaces blood from the lower part of the body to the heart and increases cardiac output. Fifth is the resorption of the fluid from the interstitial fluid. Due to the adrenergic discharge, the arterioles precipitately precapillary sphincters, postcapillary sphincters, the venules, and the small veins of the skin. And the sixth is the resorption of the fluid from the intracellular to the extracellular space, release of the epinephrine from the adrenal medulla, cortisol from the adrenal cortex, and glucagon from the pancreas, and inhibition of release of insulin all lead to the high extracellular glucose concentration. Then next is the renal conservation of body water and electrolytes. These are the compensatory mechanisms of the hypovolemic shock. Adrenocorticotropic hormone is released by any stress including shock. This hormone and angiotensin 2 stimulate the synthesis and release of the hormone aldosterone from the adrenal cortex. Now the clinical features. The clinical features of the hypovolemic shock depends on the degree of the loss of blood volume and on the duration of the shock. First is the mild shock. Loss less than 20% of blood volume is included in this category. And in the moderate shock, loss of the blood volume from 20 to 40%, there will be the oliguria. This oliguria is due to the adrenergic discharge along with the effect of the circulating aldosterone and vasopressin. The pulse is also increased but usually less than 100 beats per minute. Pulse rate and the blood pressure are never the main sign of the shock. Always remember this, student. And third is the severe shock. Loss of the blood volume of more than 40% usually causes severe shock. At this stage, there is a pallor, skin of the extremities becomes pale, low urinary output, rapid pulse, and low blood pressure. Now, the clinical monitoring in hypovolemic shock. Once the shock is diagnosed, constant monitoring of the patient is required to assess the degree of blood loss and hemodynamic impairments. That is, first monitoring is the blood pressure. Measurement of the blood pressure is very essential in shock, though it may be normal in mild shock. Second is the respiration. Hyperventilation, that is, increase in the rate and depth of the respiration, is an important indicator of the shock. Hyperventilation is a normal response for every shock. Third is the urine. Urine output is a good indication for severity of shock. Urine output is affected quite early, even in moderate shock. It is also good index of the adequacy of replacement of therapy. And next is CVP. Measurement of central venous pressure is quite important in assessing the shock. The hypovolemic shock, the blood volume is decreased, so is the CVP. Whereas the cardiogenic shock, there is no depletion of the blood volume and the CVP remains normal. Next is the ECG. In severe shock, electrocardiogram may show sign of the myocardial ischemia with depression of STT segments. And next is the Swan-Ganz catheter. This catheter is used in sophisticated centers to get the valuable information about the precise diagnosis of the circulatory derangement of the shock. This catheter provides three types of the information: A, flow in the cardiovascular system; B, sampling of the blood from the pulmonary artery to give the accurate measurement of the blood gases in the mixed venous blood; and third is the filling pressure of the both right and left side of the heart can be measured. Now, the treatment of the hypovolemic shock is first mainly the treatment of the hemorrhagic shock, which is the most commonly form of the hypovolemic shock, is as resuscitation. This should be begins immediately as the patient is admitted with the hypovolemic shock. This starts with establishment of a clear airway and maintaining adequate ventilation and oxygenation, lowering of the head of support of the jaw to prevent airway obstruction, and administration to oxygen as are usually all that are needed. Lowering of the head will improve venous return, preventing stasis of blood in the muscles of the leg and preventing edema. Second is the immediate control of bleeding is highly important in case of hemorrhagic shock. This may be achieved by the raising of the foot end of the bed and by compressing bandage to the tamponade external hemorrhage. And third is the extracellular fluid replacement is probably the most important point in the treatment of the hypovolemic shock. Resuscitation should always be started with crystalloid solution even if the blood is available. If resuscitation is started with acidotic cold bank blood with a potassium concentration, efficiency of myocardium is tremendously jeopardized. 3 liters of fluid given over 45 minutes should resuscitate any patient with arrested hemorrhage. It must be remembered that blood substitutes like plasma or dextran should only be used when whole blood is not available. If whole blood is available, these substances should not be infused before transfusing blood, as this may cause difficulty in cross matching and may inhibit the clotting system and exacerbate bleeding. So always students remember that before giving the sample for the blood group and cross matching, you should not give blood substitute like plasma and dextran before taking the sample. So this may make difficult in cross matching and clotting system. A few points to be remembered in case of the extracellular fluid replacement, that is the IV fluids, particularly the crystalloids, which should be given first, is administered with rapidly so that the replacement is done as quickly as possible without burning the heart. Second is to know how much fluid should be given. Blood pressure, pulse rate, urine output, CVP and other laboratory tests should be performed. If there is a blood loss, it is best replaced by the blood. Blood substitutes cannot take place of the blood. If blood is available, blood substitutes are better avoided. And fourth is the drug. A few drugs are sometimes used in the different types of the shock, like sedatives, chronotropic agents and inotropic agents. In the sedatives, these drugs are commonly used to alleviate the pain in the patients with shock. For children, barbiturates are preferred, whereas in the head injuries, that is the Lariactic is a better choice. Chronotropic agents, the patient in shock who have shown heart rates may benefit from the administration of the chronotropic agents, which primarily increase the heart rate. Atropine is the most widely used in this group, followed by isoproterenol. Rapid heart rates requires increased myocardial work, which in turn requires increased coronary blood flow. And third is the inotropic agents. These drugs improve the strength of cardiac muscle contraction. Patient in cardiogenic shock and in severe septic shock may require such drugs. The most commonly used drugs in this group are dopamine and dobutamine. These drugs in low doses increase myocardial contractility and selectively increase renal blood flow by dilating the renal vasculature. And fourth is the vasodilators. Some patients in severe septic and traumatic and in cardiogenic shock may require the drugs. The most commonly used drugs in these groups are nitroprusside, nitroglycerin, as they are easily reversible and short acting. Vasoconstrictors, these drugs are particularly beneficial in neurogenic shock. Beta blockers, patient in cardiogenic shock with stripped myocardium and rapid heart rate will benefit from the administration of the beta blocker. The drug increases efficiency of ventricular contraction. The drug, however, should be used with caution as it induces a slower heart rate. Propranolol is the most widely used drug in this group. And next is the diuretics. These drugs are sometimes used in treating patients with cardiogenic shock. These drugs reduce the vascular volume and decrease filling pressure. Now, next is the traumatic shock. Pathophysiology of the traumatic shock is the peculiarity of this shock is that traumatized tissues activate the coagulation system and release microthrombi into the circulation. These may occlude or constrict the part of the pulmonary microvasculature to increase pulmonary vascular resistance. This increases right ventricular diastolic and right arterial pressures. Now, the clinical features of traumatic shock are almost similar to those of the hypovolemic shock. The two differentiating features are, first is the presence of the peripheral and pulmonary edema in this type of the shock, and second is the perfusion of large volume of fluid which may be adequate for pure hypovolemic shock is usually inadequate for traumatic shock. Now, the treatment, first is the resuscitation. In this type of shock, mechanical ventilator support is more needed, and second is local treatment of trauma and control of bleeding. This is almost similar to the hypovolemic shock. Third is the fluid replacement. As mentioned earlier, more fluid should be required to bring back the patient to normalcy than hypovolemic shock. Now, the next is the cardiogenic shock. Pathophysiology of the cardiogenic shock, it is usually due to the primary dysfunction of one ventricle or the other. Such dysfunction may be due to the myocardial infarctions, chronic congestive heart failure, cardiac arrhythmias, pulmonary embolism or systemic arterial hypertension. Dysfunction of the right ventricle, the right heart is unable to pump blood in adequate amounts to the lungs. Filling of the left heart decreases, so left ventricle output decreases. Now, the clinical features of the cardiogenic shock is, in the beginning the skin is pale and cool and the urine output is low. Gradually the pulse becomes rapid and the arterial blood pressure becomes low. Now, the treatment of the cardiogenic shock is the airway must be clear with adequate oxygenation. In case of the right-sided failure caused by a massive pulmonary embolus, should be treated with large doses of the heparin intravenously. Now, the next shock type is the neurogenic shock. In this type of the shock, there is a dilatation of the systemic vasculature which lowers the systemic arterial pressure. Blood pools in the systemic venules and small veins. The right heart filling and stroke volume decreases. Clinical features, the peculiar features are that in the skin remains warm, pink and well perfused in contradistinction of the hypovolemic shock. Treatment is that elevation of the legs is effective in the treating the patient with neurogenic shock. Second is the administering fluid is important, though not so as in hypovolemic shock, but important. Third is the neurogenic shock is probably the only form of shock that can be safely treated with the vasoconstrictor drugs. Its prompt action saves the patient from sudden low blood pressure and low cardiac output from the imminent damage to the more important organs like brain, heart and kidney. Now, the next shock type is the septic shock. During the past few years, there have been a progressive increase in the incidence of the septic shock. The most frequent causative organisms are gram-positive and gram-negative bacteria. Though any agent capable of producing infection, including viruses, parasites and fungi, may cause septic shock. Gram-positive sepsis and shock. This type of the shock is usually caused by the dissemination of a potent exotoxin liberated from the gram-positive bacteria without evidence of bacteremia. This is noticed more oftenly in Clostridium tetani or Clostridium perfringens infections and fulminating infections from Staphylococcus, Streptococcus and Pneumococcus organism. Such shock is basically caused by the massive fluid losses. Now, the gram-negative sepsis or shock, the most frequent source of the gram-negative infections is the genitourinary system. Gram-negative sepsis is cause of shock is a difficult problem. Now, the clinical features of the septic shock are, septic shock is often recognized initially by the development of chills and elevated temperature above 100 degree Fahrenheit. Two types are usually clearly defined, early warm shock and late cold shock. In early warm shock, there is a cutaneous vasodilatation. The toxins from the infected tissues increases the body temperature to bring this temperature down. The late cold shock, there is an increased vascular permeability due to the liberation of toxic products into the center circulation. treatment. The only effective way to reduce the mortality in septic shock is by prompt diagnosis and treatment. Treatment can be broadly divided into two groups. One, treatment of the infected by early surgical debridement or drainage and by use of the appropriate antibiotics, and second is the treatment of shock, which includes fluid replacement, steroid administration and use of the vasoactive drugs. Search for the source of infection is made while treatment of shock is started with fluid replacement. That is the cephalothin 6 to 8 gram per day, IV in the 4 to 6 divided doses, gentamicin 5 mg per kg per day, clindamycin particularly when infecting organism in bacterides, or chloromycetin particularly in case of the bacterides infection, are the antibiotics which may be started in the beginning. Second is the fluid replacement is of great importance in late septic shock. Mechanical ventilation along with the endotracheal intubation is frequently needed in treating the patient with the late septic shock. Steroids have been used for quite some times in the treatment of the septic shock. It has been suggested that the steroids protect the body cell and its content from the effect of the endotoxin. Larger doses of the steroids are known to exert inotropic effects on the heart and produce mild peripheral vasodilation. Short term, high dose steroid therapy is recommended. Dexamethasone is given intravenously in 5 to 10 minutes. Now, the next point is the vasoactive shock. Use of the vasoactive drugs with mixed alpha and beta adrenergic effects, that is the metaraminol, may be indicated. Inotropic agent, that is the isoproterenol and dopamine is ideal when simple value replacement and other measures have failed to restore adequate circulation. Dear students, here is the end of our surgery lecture number 71, that is the shock. Thank you.